Good morning. Transscleral cycloablation with micropulse laser technology. Definition of glaucoma. It's difficult to define glaucoma precisely because the term encompasses a diverse group of disorders. Anyhow, progressive optic neuropathy that is associated with visual field loss and damage progresses, and in which IOP is a key modifiable factor. A brief review of anatomy and physiology of aqueous humor production and drainage. Trabecular meshwork, trabeculum is a sieve-like structure at the angle of the anterior chamber, which the main drain of aqueous through this way. It composes three components of uveal and corneoscleral and juxtacanalicular meshwork. A slim canal is a circumferential channel within the perilimbal sclera. It composes inner and outer layer, connected directly or indirectly with episcleral veins. Aqueous humor from the posterior chamber through the pupil and then drain via three routes, which is mainly trabecular outflow and uvascular drainage and iris. Glaucoma affects 2 to 3% of people over the age of 40 years. Unfortunately, 50% may be undiagnosed. It's either primary open-angle glaucoma, which is the most common in whites, in Latino and black individuals. Primary angle closure constitutes up to half of cases, higher prevalence in individuals of Asian descent and Caucasian individuals. There's many types of glaucoma, either primary open-angle glaucoma or normal tension glaucoma, or primary angle closure glaucoma and secondary glaucomas. Secondary glaucoma, either pre-trabecular or trabecular or post-trabecular glaucoma. Pre-trabecular, either fibrovascular tissue or endothelial tissue or epithelial cell which clog or occlude the trabeculum. The trabecular cause either pigments or red cell or degenerative red cell or macrophage or protein, pseudo-oxyphilic material or other like edema or scarring. Post-trabecular, either carotid cavernous fistula or Sturge-Weber syndrome or obstruction of the superior vena cava. Types secondary glaucoma either with pupillary block or without pupillary block. With the pupillary block, as in seclusio pupillae or subluxate lens or phacomorphic glaucoma or capsular block syndrome or aphakic pupillary block or anterior chamber lens implantation without the use of iridotomy. Also without a pupillary block as secondary cause of peripheral anterior synechia, such as advanced neovascular glaucoma or ciliocoroidal effusion or capsular block syndrome or ciliary body iris cyst or contraction of lateral-lenticular fibrovascular tissue. Treatment, either medical treatment, topical medication use, topical medication, or sometimes in short-term use systemic medication. Or second line of treatment, laser treatment, either laser trabeculoplasty, iridotomy, or laser cycloablation or iridoplasty, laser iridoplasty. Also, the main surgical treatment is trabeculectomy, which is the gold standard procedure since 1998. Or non-penetrating glaucoma surgery as drainage device or drainage device using episcleral device, Molteno or Ahmed Vab and other. Or sometimes use mini shunts, Express and mini shunt, iStent, Hydra, Cypass and other. Laser use in glaucoma, either argon blue, green or green laser, or diode laser, or Nd:YAG laser, and carbon dioxide laser. In diode laser, there is a semiconductor diode laser deliver through continuous wave of infrared 810 nanometer. There is a two pulse type are available, either continuous wave pulse or micro pulse. Continuous wave pulses laser emission is continuous during the entire fired exposure. In micro pulse laser delivery consisting of group of microsecond bursts. The fiber optic tip of the micropulse is 600 micrometer in diameter. Also, the fiber optic tip protruded about 0.4 millimeter from the handpiece to allow accurate positioning at 3 millimeter posterior to the limbus to avoid, prevent damage of the cornea and does not affect the corneal stem cells. This is the probe of micropulse diode laser. There is two sides. There is a notch, red mark notch, which is usually directed toward the limbus, and flat side directed toward the eyelid. Micropulse diode laser therapy, which is thermally affects without destroying pigmented trabecular meshwork cells, create no visible tissue reaction. Smaller spot size, 300 micrometer, to better access narrow angles, allows the tissue to cool between laser pulses and minimizing or preventing the tissue damage. Treatment risks are reduced or eliminated. Also increased patient comfort than with conventional diode laser cyclophoto ablation or coagulation. Can be used in conjunction with drug therapy. Also, and allowing complete and optimized management of retinal disease and glaucoma without laser-induced damage. This is the comparison of the probe of micropulse laser and the probe of G-probe, regular probe in cyclophotocoagulation. The probe in micropulse laser positioned perpendicular to the ocular surface to avoid corneal damage and directed toward the ciliary muscle directly. Laser ablation usually used at 9:30 and 2:30 from above and below 3:30 to 8:30 o'clock positions. In G-probe, this is the probe of G-probe, the position directed toward the ciliary body, probe directed parallel to the visual axis, and hand parallel to the visual axis to directed toward the stroma and ciliary epithelium of the ciliary body. The application, it depends either quadrant or two quadrant or three quadrant of the circumference of the limbus. This is the handle of the handpiece of cyclophotoablation with micropulse laser using the superior and inferior hemisphere of the globe. Pre-op care usually use anesthesia, either retrobulbar or peribulbar block. Retrobulbar or peribulbar block use 2% lidocaine without epinephrine, or sometimes use propofol as a general anesthesia in some certain cases. We use lubricants such as goniovisc or lidocaine gel as a lubricant for during painting or sweeping of the micropulse laser. Use globe control instruments like forceps or any other globe control. We use marking pen to marking the sites of laser ablation. Even meridian marks are on the globe to avoid 3 and 9 o'clock. Sometimes we need marking the notch on the micropulse laser MP3 probe head. Post-operative care. If we use topical, local peribulbar or retrobulbar anesthesia, use eye patch if needed. Anti-inflammatory drugs use usually prednisolone acetate 1%, 2 to 4 times per day for 1 to 2 weeks. Sometimes use non-steroidal anti-inflammatory also may be used. Vasoconstrictor, phenylephrine if needed. This is not recommended. Not usually use any vasoconstrictor, topical vasoconstrictors. Pain medication, majority no need for any pain medication, and usually after laser continue glaucoma medical therapy adjusted based on the follow-up of the patient. Indication of the micropulse laser in any type of glaucoma, usually used in primary opening angle glaucoma or closed angle glaucoma after iridotomy. We use iridotomy and then use the laser. May be used in refractory glaucoma, usually increase the power and the time exposure in refractory glaucoma. Also used in pseudoexfoliation glaucoma and pigmentary glaucoma. It may use also as a primary therapy or failure of compliance with medical therapy, or maybe adjunctive treatment to avoid polypharmacy, or in sometimes intolerance to topical medication including allergy. Failure or sometimes failure of medical therapy as less aggressive treatment measure than the surgery. It's effectively and significantly lower eye pressure and give physician control of therapy compliance, and also leave future options open. Also, it is not incisional, minimal to no inflammation post-op. Patient downtime is significantly low. It's not cause significantly increased IOP, and the action usually start after 1 or 2 weeks. Also, it's repeatable, excellent safety profile, efficient and straightforward for physician and the patient, can be performed in operating room or sometimes in office, and predictability. There is a challenging of using of this technology in condition with abnormal ocular size or corneoscleral limbus, difficult to visualize, difficult to localize. It's usually difficult to localize the laser in these cases. Also in high myopes or post-corneal transplant patients, cellular body may be more posterior. Also challenge in albino patients who have no pigmentation. A comparison between the micropulse laser and other type of laser, SLT and ALT. It's thermally effects, not destroying pigment trabecular meshwork cells, and selective is usually selective destruction of pigment trabecular meshwork. Also, it's repeatable, as in selective laser trabeculoplasty is also repeatable. There is no visible tissue reaction. In SLT, small bubbles, or in ALT, there is a blanching, and bubbles may be used. Post-op information, none. Spot size usually use 300 micrometer small spot size to access. You use the laser in narrow angles to avoid destruction of the adjacent structure. There is a randomized study show micropulse with traditional or normal transscleral cyclophotocoagulation shows the success rate is usually higher in micropulse laser, and also prolonged hypotony. There is no hypotony at all in micropulse laser. This UPM slide show, in first slide use normal cyclophotocoagulation. There is a destruction of the ciliary body, stroma and epithelium. And next slide use this micropulse technology, show there is effect only on the longitudinal muscle of the ciliary body, which shortening and contraction of the ciliary muscle, and then opening the trabecular meshwork. I will show a video showing how to use this micropulse laser photoablation.
لو فوتو ابليجن لو فوتو ديستركتيف. وين الابليجن بالموضوع؟
Antiseptic technique, peribulbar or retrobulbar anesthesia. This countdown time for the laser. Usually start with inferior hemisphere, sweeping or painting from edge to edge, from
سلام.
side to side, inferior and superior hemisphere. This is the inferior hemisphere, and then go to superior hemisphere.
Salam, there is no video. الفيديو الصوت بس ما دا يطلع هنا.
Using antiseptic technique and anesthesia, local anesthesia, peripulbar or retrobulbar anesthesia. Adjust the machine, the cyclodiode laser, using the inferior hemisphere. From 350 to 950. This is the inferior hemisphere, and then go to the superior hemisphere. Count down.
المريض سودافيكي.
أفضل بالسودافيكي.
طبعا.
This is the superior hemisphere. This is the movements, painting or sweeping, and show the direction of the probe toward perpendicular toward the ciliary body, perpendicular to the ocular surface. This is the setting of the diode laser machine. Usually use from 50 to 90 seconds for each hemisphere. 50 to 90 seconds, and the power usually 2000 milliwatts, increase or decrease according to the patient. Usually 10 seconds for each journey. This is a subtenon injection of dexamethasone. And thank you very much.
Thank you, Dr. Salam, for sharing us in this new technology and we see all the advantages over selective laser trabeculoplasty or argon laser. Thank you very much.
Thank you.